Hello, PsychU community, and welcome to today's webinar, Integration of Behavioral Health in Primary Care, the Past, Present, and Future. We thank you, audience, for joining us today. My name is Roland Larkin. I'm a Senior Medical Science Liaison for Otsuka, and I'll be moderating our webinar, which will feature Doctors John Kern and Sloan Manning. It should be an exciting discussion. Both of our speakers are experts in the field of treatment integration, having a wealth of experience on the topic. First off, we have Dr. John Kern, Clinical Professor, Department of Psychiatry and Behavioral Sciences at the University of Washington Ames Center, Advancing Integration Mental Health Solutions. And we have Sloan Manning, who is the Medical Director of Novant Health Urgent Care and Occupational Medicine. Today's presentation is sponsored by Otsuka, OPDC, and Lumbeck, committed supporters of the mental health treatment community, and speakers are paid for their consultant work with OPDC. The information provided during this program is intended for your educational benefit only. No CME or CU credits are offered. It's not intended as, nor is it a substitute for medical care, medical advice, or professional diagnosis. Users seeking medical advice should consult with their physician or other healthcare professional. While conducting this discussion, our speakers aim to provide you with information that is accurate, scientifically rigorous, and not misleading, and will not promote Otsuka products either. You may notice that attendees have been muted. We're recording today's event and have muted the phone lines to ensure the best sound quality. However, we will hold a brief Q&A session at the end of the presentation. And to participate, please submit questions via the question box on the GoToWebinar panel at any time during the presentation. So, before we begin, I'd like to take a moment to review the objectives. The first of which is to review the origin of the integration of behavioral and primary care, sort of the past, and then identify challenges and successes of present integration attempts, the present, and of course the future. Discuss the role of technology for future of behavioral and primary care integration. So without further ado, I'm going to hand the reins over to Drs. Kern and Manning.
I kind of figured, John, that we could almost frame this as, since it's the past, present, and future, I could be the ghost of integration past, you could be the ghost of integration present, and then we could both try to kind of move into the future, because I, have spent, a 30-year career trying to, integrate behavioral medicine and primary care to one degree of success or another. You've been to the promised land. I'm still waiting to go. Let's go to the next slide, and we'll, kind of talk about where we've been in this adventure. Daryl Rozier published an article in the Archives of General Psychiatry 42 years ago. I was a junior at Mississippi State. I wasn't even in medical school at the time, where he and his fellow collaborators identified primary care as the de facto U.S. mental health services system. And nothing has changed in 42 years. Most people who receive treatment for mental health disorders present and are treated to whatever degree, good, bad, or indifferent, in the primary care sector. So 42 years later, not much has changed in terms of where people are treated. There is a system out there, John, that you've been very active in for a number of years that could make this a better system. I've told this joke before. I had one of my fellow residency program directors in Memphis chide me once a number of years ago for trying to make the family practice center in Memphis a mental health center. And I told the gentleman who was the director, I said, it already is a mental health center. I would just like for it to be a better mental health center than it is right now. John, what have you found about integration of primary care and behavioral medicine that you think is exciting and works, and that will be pushing into the future, I hope?
Well, yeah, I mean, this is when it's my turn to be the ghost of Christmas present, I can talk more about this. First of all, I wanted just to point out that Sloan and I started a conversation about this kind of work in, I believe it was 2008. Let's see, yeah, that's right, 2008 at a learning collaborative on integrated care, where he was faculty and I was the learner. And so part of the reason I mention this is just because it's kind of fun to encounter each other after this time. The other reason is that the whole point of this learning collaborative was to get organizations off the ground in terms of doing collaborative care. That was 12 years ago, and I still spend most of my time working on getting these kinds of things implemented. And in some ways, we're in a similar place. There is more of it. Collaborative care has been embraced to some degree, and there's promise. When you read what people write about what's coming and what's the new thing and what's the future of mental health care, collaborative care gets a lot of play. Implementing it is harder than it looks, and that's why we're still here. We'll talk about why it's harder than it looks. It's not unfixable. If you do it, and we'll see the evidence of this. If you do collaborative care well, it works. People get better.
Money is saved.
Money is saved, hopefully, depending on how you do it. But it's it does work if you do it. There's the old aphorism about things taking 17 years, new treatments taking 17 years to get from bench to bedside, and that's certainly been true. And in spite of attempts to speed up implementation. What I think is true is that primary care will remain the de facto mental health system. We may just be, instead of doing it kind of behind our backs, pretending we're not doing it, we'll just be overt about it, that mental health is part of primary care. Before I went to UW, I was for 2 years the chief medical officer of a federally qualified health center. So I was hiring young family medicine docs out of training. And the fact that we had a collaborative care program was a real selling point, because some kids, I want to say, some young trainees had grown up with it in their training, and they expected that was going to be part. And it was a recruiting advantage. So that was pretty interesting for me.
Yeah.
So what is this? What is this pyramid, Sloan?
Well, it's a way to the top. It's sort of a path to nirvana, if we could get there. I have practiced in family practice situations where we have set up mood disorder clinics and in-house consultations that sort of brought in expert care and really specialty care for a lot of disorders into the primary care family practice center process in collaboration with social workers, with psychologists, specialized nurse practitioners, things like that. But the idea is that you begin to do this work in collaboration by setting up a process of identifying and dashboarding and collecting information on patients, and then you bring in individuals who can help and support the care of these behavioral medicine kinds of problems. And of course, that requires some money to do. Tell me what you've seen, John.
Well, this pyramid here is from it's an AIM Center document. I think when we're looking at this, one of the things we're responding to when we look at this pyramid is the notion that we are recommending collaborative care as the solution for all kinds of care, for all kinds of clinical situations, to the exclusion of all others. And nothing could be further from the truth. There is, and so if you look at this even for a minute, you can see that it moves from less serious and less complex and less needy kinds of situations to more advanced and more complex and more specialized kinds of care. And I think that making a de facto system of mental health care, or even a real system of mental health care that addresses efficiently all of the different kinds of problems that people have, involves being mindful of these kinds of different slices of the pyramid, or slices of the pie. And so there are some things that don't need really a mental health provider at all. A well-equipped primary care office can see people with relatively straightforward anxiety and depression, or transient conditions, or common kinds of things, and especially, and sometimes with and without behavioral health providers embedded. Some things don't need really care at all. They're almost more like a little bit of reassurance, a little bit of watchful waiting, a little bit of tincture of time will take care of them. And then when you move up, you're looking more into the collaborative care management, where there's the psychiatric consultant involved, and then past us, if us is collaborative care, into the traditional specialty behavioral health care world. The psychiatrist's office, the mental health center, and of course the hospital at the top, which you're trying to avoid, of course. I think the things to point out here is that, well, one of them is that what a stepped strategy, in other words, trying the simplest things first and seeing if they work, what that does is it increases access. There's a slide coming that's going to talk about the difficulties with access to psychiatry, and that's a huge bottleneck. It's the rate limiting step in terms of moving care forward. And so what this does is make it so that essentially you don't have a psychiatrist seeing the simple stuff, to be kind of simplistic about it, and you have simple solutions for simple problems, and then you don't end up with a bottleneck. Everything doesn't have to route through the psychiatrist. The psychiatrist can be involved in more complex care, and in the case of the collaborative care situation, being involved via a consultative model to a much larger, maybe 10 times as many patients as they could if they were just seeing them themselves face to face. So this does a couple things. It doesn't waste people's time, and it doesn't waste resources. And of course, the behavioral health is such a limited resource.